So this is chapter 19, endocrine and hematologic emergencies. Your endocrine system truly directly or indirectly influences pretty much every cell, organ, bodily function, you name it, it's helps or influences it. So endocrine disorders can be seen with multiple signs and symptoms because it kind of depends on what specific portion is involved. Hematologic emergencies are really difficult to assess and treat in the pre-hospital setting because we can't run lab tests really quickly. However, that doesn't mean that we don't make a significant difference in the outcome of that patient. The endocrine system communicates and controls functions within the body utilizing hormones, which are basically chemical messengers. They're produced by glands and they travel through the blood to either end organs, tissues, or cells that they end up affecting. Whenever the hormone arrives, a message is received and then some sort of action takes place. So endocrine disorders are really caused by some sort of internal communication problem. If the gland is not functioning the way it's supposed to, it may produce more hormone than needed, which is called hypersecretion, or not enough hormone, which is hyposecretion, or the gland itself may be functioning just fine, but the receiving organ doesn't end up responding the way that it's supposed to. We need to talk about glucose metabolism because one of the most common endocrine disorders is diabetes. So your brain needs two things to survive: glucose and oxygen. We've talked about this a couple of times. In order for your brain to actually receive the glucose that it needs, you have to have insulin. Insulin's like a key that unlocks the cell to allow the glucose into it. If you don't have enough insulin, or your cells don't respond to the insulin that you do have, the cells don't get fed, period. So the pancreas produces and then stores two different hormones. So you have glucagon and you have insulin. The specific portion within the pancreas that actually produces this is called the islet of Langerhans, and there's relatively small portion of the pancreas that actually has these. Within those islets, there's alpha cells and there's beta cells. The alpha produce glucagon, the beta produce insulin itself. The pancreas then stores and then secretes either insulin or glucagon in response to the level of glucose within the blood. So diabetes is a disease that forms when your body can't utilize glucose for fuel. It affects about 9.3% of the overall population. Without treatment, blood glucose levels become too high because that sugar can't actually get into the cells. In really severe cases, it can cause coma, it can lead to death. I mean, it can be pretty serious. And then if it's not managed well, then there's a bunch of other severe complications that you can have, such as blindness, cardiovascular disease, and kidney disease. So there are 3 types of diabetes. There's diabetes mellitus type 1, diabetes mellitus type 2, and pregnancy-induced gestational diabetes. So how do we treat them? You can either do medication or injectable hormones that help lower that blood glucose level by allowing glucose to get into your cells. If that medication is administered improperly, then it can create a medical emergency for the patient. They may have taken too much of their medication or not eaten, and they'll end up with low blood glucose levels, which is called hypoglycemia, hypo being too low, or they can end up with a condition called hyperglycemia, where their blood sugar gets way too high. You can have hyperglycemia and hypoglycemia in both type 1 and type 2, but Some is more common in type 1, one is more common in type 2, and we'll get there. All hypoglycemic patients require prompt treatment. They need sugar to try and bring up their blood sugar. So we have ways to fix that. For diabetes type 1, it's actually an autoimmune disorder. So your body is attacking itself. And truly, we have no idea why this is. But what happens is the body actually attacks those beta cells that make the insulin. Without insulin, there's no key to open the door for the glucose to get from the blood into the cells where the cells actually can use it, because remember, that is one of their types of fuel. And so typically how it works, we used to call this juvenile diabetes because this was normally kids that ended up getting it. However, it's not like that anymore. People are getting type 1 diabetes for all sorts of different reasons well into their adulthood. So we don't call it juvenile anymore, we call it type 1. By the time that your body actually shows signs of diabetes when you have type 1, about 80% of your beta cells have already been destroyed, and there's no way to make those come back. Even if they do beta cell transplants, pancreatic transplants, your body still ends up taking out those beta cells. So there's really no quick fix. So what you end up doing is you are required to measure your blood sugar all the time, like before meals, after meals, etc. Kind of depends on how bad you are. And then you have to have insulin injected. And a lot of times it's going to be based on what you eat. Some people are on 2 different types of insulin. They have a long-acting insulin, and they give themselves what's called a bolus, so one big dose that lasts them throughout the day. And then they end up taking varying amounts of insulin just for specific meals, and that's short-acting. If a patient has an insulin pump, which sometimes is just super easy for them to be able to manage their blood sugar, they can do a finger stick. Some of them, the pumps can actually check. They have to program how much insulin they're going to get out of the pump. So always double check to see if there is an insulin pump in somebody that's showing signs of a diabetic emergency. Not only is the pump present, is it turned on, and is it still plugged in? It goes through a little needle into the skin and it just sticks there. So double check to see if that's going better for them and if it's working properly. Type 1 diabetes is the most common metabolic disease of childhood, and those that have new onset diabetes will have a lot of symptoms that really relate to eating and drinking. So they pee a lot, they want to eat a lot, they want to drink a lot, they have weight loss, and then they're often pretty tired. So their body's trying to find ways to take in more sugar because their cells are basically saying, hey, we're starving here, you've got to eat more. And it doesn't work because no matter how much they eat, they're not getting that glucose into their cells. And so they continue to eat, doesn't do anything. But they end up putting quite a bit of sugar into their blood. Their cells don't know it's there, but it is there. And the only way to get rid of it is to actually pee it out. And so their body constantly is trying to pee out all of that extra glucose, which then dehydrates them, which makes them very thirsty. And then one of the other ways that your body ends up getting to potential glucose is that those fat stores that you have, those glycogen chains, your body will actually start burning those off because that's your reserves. And so you'll start burning fat, and that manifests in some pretty severe weight loss. But that still doesn't make a difference because you're missing the insulin, so you're missing the key. When your body starts burning down that fat, you end up producing a waste product that for all intents and purposes, we'll just call it ketones. So your kidneys can't maintain that acid-base balance either when you're burning that much fat. And you go into what is called ketoacidosis. So you actually start dropping your blood pH because you're becoming more acidic because of these ketones that are being released. So what the patient starts to do is they start to breathe in a really weird pattern. So they're called Kussmaul respirations. So what you end up doing is you breathe faster and breathe deeper, breathe faster, breathe deeper, breathe faster, breathe deeper, and then you have a short period of apnea or no breathing. And then you continue to build up. And it's a pretty recognizable respiratory pattern. And it only happens when somebody is in DKA, so diabetic ketoacidosis. So other signs of DKA, it can just present as a generalized illness. So abdominal pain, body aches, nausea, vomiting. If it gets severe, the patient can be altered or unconscious. So typically if somebody says that they have a history of diabetes or they're altered in any sort of way, we're probably going to check a finger stick glucose at the very least and see how their sugar is. If you obtain a blood sugar that's greater than 400, it is likely that the patient does have ketones present. However, there are some people that live every single day somewhere between 200 and 400. So that may not truly be high for them. So you need to just double check, how their sugars usually run. Because somebody that runs super high all of the time, they may be hypoglycemic or exhibiting the signs and symptoms of low blood sugar even before they get to 200, if they're usually at 400. So this is all relative to the patient themselves. Diabetes type 2 is a little bit different. So the body is not attacking itself and getting rid of those beta cells. Those tend to be just fine, and you produce a relative normal amount of insulin, but your cells have become resistant to that insulin. So instead of the key fitting right in the lock like it's supposed to, now all of a sudden the key doesn't fit so well. And so not enough glucose gets into the cells like it's supposed to. There is a link between obesity and increased resistance to insulin. And so people that are overweight tend to have increasing instances of diabetes type 2. The pancreas is then going to try and produce more insulin to make up for the decreased levels of blood glucose because it doesn't quite realize what the issue is. Sometimes you can actually reverse this process by exercise and controlling it with your diet. Other times you may have to progress into medications, but they really start first and foremost with diet and exercise, and then some oral medications as well. So some medications actually work to increase the secretion of insulin. However, this makes the patient more susceptible to a hypoglycemic reaction. So the preferred way to do this is to actually give a medication that stimulates the receptors on cells to be more sensitive, is what we call it, to insulin. And oftentimes that means just increasing the number of actual receptors to try and make it so that insulin will activate it. Others end up decreasing the effects of glucagon, which goes into the blood to try and raise blood sugar. And then others will decrease the store of glucose in the liver, so try and decrease the amount of glycogen that's actually created. And we'll go on in the next one.